Please welcome our panel to the stage. Thank you. Heard a little bit about what stem cells can do for the spine and for orthopedic injuries. We're also now going to hear about how it can impact cardiovascular disease, pulmonary disease, and neurodegenerative disease as well. So we get a chance to talk again, Dr. Glassberg.
Yes, we do, Sanjay.
We'll kick it off with you.
Good morning, everybody. Thank the organizers, thank Robin, Matt, and the rest of you for a very exciting return to the Vatican. This morning I'm going to talk to you about lung disease. We're going to shift gears a little bit. We're going to talk about chronic lung diseases, and I'm going to focus initially on idiopathic pulmonary fibrosis, probably the most deadly of over 300 causes of interstitial lung disease and fatal. And what you see in this picture is the perimeter. As you go around this CT scan, you see lots of holes. This is fibrotic lung, and the lung is a defective organ that doesn't know how to heal. But as you heard yesterday, this process actually starts as an inflammatory process, and it's been debated for a long time. But we know now that if we look sort of behind the scenes of now looking at this really, the black stuff that you see in the middle is normal lung, and then what you see that's cast around, as I mentioned to you, is fibrotic. It's holes, almost looks like a beehive, where the lung is really destroyed. And what does this do to patients is that they can't breathe anymore. And so their oxygen levels go very low, and they become dependent on oxygen, they become respiratory cripples, and they die. They die fairly quickly within 3 to 5 years. But behind the scenes of this is a very complex pathway that we're only beginning to understand. But I want to focus you a little bit on some of the things that are in this slide, because you're going to hear about them this afternoon. You're going to see the Wnt pathway, you're going to see things that look like inflammatory cells that we've already talked about, macrophages, but what really happens here is the little bullet in the front, the little dagger of injury. There's an injury. And the lung is susceptible, obviously, to the air that we breathe every time we pull the oxygen in. We don't store the oxygen. And so this injury creates a terrible cascade. And this cascade creates the holes. Now, this isn't a disease that hasn't been worked on. In fact, we have 2 approved drugs for this disease, neither of which cure. So there are 2 of them, nintedanib, known as Ofev, and pirfenidone, known as Esbriet, that have been approved in the European countries in the early 2011, 2010 initially, and then ultimately in the United States in October of 2014. So why show this slide? This shows the extensive worldwide effort at trying to find drug or drugs to treat this disease. There are none. You can see that none have come to fruition as yet. But I want you to notice here that in the middle pathway where it says MOA, mechanism of action, you can see that there are really many things that are targeted, many factors that we've already talked about yesterday, more to come today. But in light of the fact that the 2 approved drugs only slow progression of the disease and don't cure it, we decided to look, in 2013, we applied to the FDA to look at mesenchymal stem cell therapy in these chronic lung diseases. The first one we chose was idiopathic pulmonary fibrosis because of really its death, so-called death benefit, that it's very fatal. It affects men over the age of 50, retired, ex-smokers. They like to play golf. They tend to ride the cart after a while, and if they can't play singles tennis, they're playing doubles, and then they're using their oxygen in between. So this is just to show you the progression, very fatal, to see the extensiveness of that whole process as you go across this slide. And you can see in the bottom, that's the pathology, where there's no more normal lung left that you see on the initial side of the slide. As you cast your eyes across, it looks like islands of empty tissue. So 5-year survival rate from diagnosis, 20 to 40%, 2/3 over the age of 60. Most patients actually presenting in their early 50s if we're lucky enough to see them with shortness of breath and a dry cough. So let me show you the study very briefly. This was published last year now. We enrolled 11 patients, treated 9 of them, 7 of them completed follow-up. What's important here is that this was safe. This was a phase 1 trial. For everybody to understand, phase 1, phase 2, phase 3, this is the way we have to go. I see Ed there looking that we'd like to fast track this, but the phase 1 was safe. Was that the most important thing that came out of this? Actually not. What came out of this was the urge to look at chronic lung disease because now we had demonstrated safety. But if we look at the design of this study, there were 3 groups of patients in here. Remember, there's 9 that complete, 3 getting a low dose of 20 million cells, 3 getting 100 million cells, and 3 getting 200 million cells. And the primary endpoint safety, but I want to focus you in the next slide really on what we looked at, which is called the DREAM. So in a phase 1 study of secondary endpoints, you're looking to see, is there anything that you might be able to think about in the future to be able to do more work in this area once you've demonstrated safety, and we did. So let me show you the secondary efficacy outcomes. This is a 60-week study, the longest study ever done in man. These are allogeneic cells. In contrast to what you heard in the previous session, these are cells from male donors age 19 to 26 who are healthy. If we use a patient's own cells for lung, which we did the initial animal models and published them, autologous cells did not work. So what do you see here? You see straight lines. This was the first study, actually, that we could dream for stability. In all of the studies, including the 2 approved drugs, there's a steady decline in lung function, just like you saw in the pictures that I showed you with the CAT scan and the pathology, this sort of steady, aggressive approach to what happens to disease. These patients stabilized. But that's lung function at the top, forced vital capacity and diffusion capacity. If you look at the bottom of the 6-minute walk test, you see some dips. I want you to keep in mind those dips, because that's what fueled us for what we're currently doing. The walk test didn't stay completely stable. This was 1 dose, remember, from a donor. But what we were allowed to do was to do some new studies looking at trying to put some math behind CT scans. So pictures are pretty, calculations are better. We worked with a physicist and radiologist at the UCLA, John Golden, who's pioneered this. This is just to show you one case of a baseline to week 24 to week 48, and what are you looking at? The yellow is inflammation, the red is fibrosis. And what we can see as we go across, this is cohort 2 getting 100 million cells. We can see that the yellow gets less, the red gets less. So we've been able to in a very sample case, this has been now submitted to the American Journal of Respiratory and Critical Care Medicine, that we have decreased the inflammation and decreased the fibrosis. Well, those are pictures. I didn't bring all the mathematical stuff that's in the paper, but I do show you, I think, a very nice picture of the blue line at the top is cohort 1 getting the low dose, and the bottom dashed line is cohort 2 getting 100 million cells, matched to a subject another subject, showing you that indeed there was less inflammation and less fibrosis. Why is this so important? Because this is the cascade. Just like we spent a lot of time yesterday talking about how does it all start, this all starts as an inflammatory pathway. So it becomes very important to attack from the beginning. So in conclusion then, subjects in cohort 2 progressed more slowly. These are quantitative lung fibrosis scores that I just showed you in the prior slides. A mean of 2.38% seems small, but it's huge in the lung. With cohort 1 during the baseline to 48-week interval, subjects in cohort 2 also had less decline in their, an increase in their predicted diffusion capacity. Very important in lung disease. This is how we get around and how we gas exchange in our lungs, and that's our measurement. They also did improve in the 6-minute walk test, but as I showed you, there were 2 little blips in the walk test, one occurring early on and one occurring later. And so that led us to get to reapply to the FDA for our phase 2 study called RECELL, in which we will look at 21 IPF patients with forced vital capacities greater than 45% predicted, diffusion capacities greater than 30%. What does this mean? It's a little bit more moderate group of patients since we've now shown safety, and so we are waiting funding to begin this study. So where does this take us? This takes us to where should we go from here, and really through the benefit of some wonderful foundation that's in the audience, Marcus Foundation and Fred Sanfilippo, we were able to extend this work now to more chronic lung diseases. We've completed enrollment now on CELEB, which is a study in non-cystic fibrosis bronchiectasis patients. So it's very interesting. This is a chronic inflammatory disease with infection. These mesenchymal cells have potent effects on inflammation and on bacteria. And so this study is a safety study that will then move on to a multi-center study trying to compare other sources of stem cells. So we try to find what is the best source and what is the right dose. Aztec is a study in mild to moderate asthmatics that's currently enrolling, once again driven by our interest in inflammation. And then finally, BOSS. Can we prevent lung rejection in lung transplant? What happens to patients in lung transplant is they have a 5-year, 50% survival. They all ultimately reject. They may not show that clinically, but once again, driven by inflammation. Here we've spent hundreds of thousands of dollars to transplant them, and they don't perform well. So we're trying to figure out something that may be able to affect there. They've been a small preliminary safety study that looks to be of some benefit. And finally, I don't do this alone. I do this with a wonderful group, some of them shown here, Dr. Sharon Elliott, the lab, my clinical trials group that have been with me for over 20 years, the Lester and Sue Smith Foundation, the Marcus Foundation, and Fred Sanfilippo, Favre Foundation, Samrick Foundation, and the NHLBI. Thank you very much.
Thank you. That was fantastic. Thank you. Very well done. And before we move on to cardiovascular disease, let me just ask a quick question. You know, when we think about disease, we often think about a therapy, a drug, an operation, whatever it may be. Given the nature of stem cells, do you think it'll be necessary to study all diseases individually, or would stem cell, once you make some of these conclusions and provide some of this evidence, could it be more broadly applied?
I think we're going to get some of that answer in terms of the work we're doing now, looking at some of the main chronic diseases. I'd like to think there's some specificity to what happens, but I think that the overall process, until we figure out what exactly it is in these stem cells, is it the exosomes? Is it part of these microparticles? Can we purify out what it is and better understand responders and non-responders? I think we'll get an answer to that.
Okay, great. And we'll talk a little bit more about that in a second, but Dr. Losordo, over to you. Thank you.
Great. Thank you, Sanjay. Good morning, everybody. I want to thank Robin, Monsignor Trafny, the Pontifical Council on Culture for, again, assembling a spectacular event. My name is Doug Losordo, and I work for Caladrius Biosciences, a company that is dedicated to developing cell-based therapies for chronic human diseases. And this morning, I'll talk to you about a long-standing program for cardiovascular repair. You know, when I was in medical school, patients who had heart attacks, who had heart failure, got a lot of TLC, but not a lot of medication was yet proven to be beneficial. And during the course of my career, of course, we've seen many new drugs and many new procedures that have been proven to work in terms of alleviating the symptoms that occur in patients who have heart disease. But what we've not seen yet is the ability to reverse the ravages of heart disease. You know, back in the old days, before antibiotics, if a patient got pneumonia, there was a good chance they were going to die. Now with antibiotics, if you have pneumonia, there's a very good chance you'll be cured. And what we want to see happen in cardiovascular disease is not managing the disease, but really reversing it and returning the patient back to a state of health. So this is really the punchline of my talk, if you will. It's a partial listing of the randomized, double-blind, placebo-controlled studies that have been done to evaluate a cell treatment for chronic ischemic disease, that is heart disease or disease of the lower extremities that results from a lack of blood supply, clogging of the arteries, robbing the tissue of the needed oxygen for full function. And so these 700 patients worth of clinical trial data have accumulated over the course of the years that provide a substantial body of evidence that the stuff really works and really reverses the disease. But you don't have to take my word for it. I'll show you some of the data. This started in 1997 when two colleagues of mine, Takayuki Asahara and Jeff Isner, who were working in Boston at the time, published this paper in the journal Science, in which they showed evidence that in the circulation of adult humans, there was a stem cell that was capable of repairing and replacing lost blood vessels in ischemic tissue, like in the heart and legs. And this photomicrograph that you see here shows evidence of those cells homing into the target tissue that was damaged by a heart attack. And that's the beautiful thing about cell therapy, is we don't have to train these cells to do what we want them to do. They already know. This is a pre-programmed repair kit that's been pre-installed in our bodies by nature. A few years after that discovery, a group in Germany published a paper in the New England Journal of Medicine in which they made the observation that patients who came in with a heart attack, who were really good at mobilizing their own CD34 cells, ended up having very good outcomes after the heart attack, and patients who were not such good mobilizers didn't do so well. So a natural experiment, if you will, proving that if your body's own repair mechanisms were working at a high level, you were going to walk away from a heart attack in pretty good shape. Our job as physicians was to try to take those patients who are on the lower end of that curve and figure out how to have them take full advantage of that repair capacity in their body. Alfred Kocher, who was working with Silviu Itescu at Columbia at the time, published a paper in Nature Medicine in which he did a very interesting therapeutic intervention in an animal model of a heart attack, but he used human CD34 cells and showed that these cells, which in that original Isner paper in 1997 looked like they were capable of restoring the circulation after a heart attack, Alfred and Silviu showed in a very nice animal model that human CD34 cells applied right after a heart attack resulted in a reconstitution of the microcirculation. They grew new blood vessels that had been damaged or destroyed by a heart attack. The other area of interest that we've been looking at is critical limb ischemia. And you don't have to be a physician, I don't think, to look at these angiograms of two different patients' legs. The one on the left showing a normal circulation with robust blood vessels supplying the lower extremities, and then the patient on the right whose blood vessels have basically been destroyed, resulting in decreased blood flow, pain at rest, and ultimately non-healing ulcers and gangrene that can lead to amputation. So we've been trying to apply the same blood vessel building strategy in patients with CLI. These are the ravages of CLI, as I was just saying, non-healing ulcers. You can see a cold white foot, and then ultimately the requirement for amputation. Well, when I was at Northwestern University, we did a study of CD34 cell therapy in patients with critical limb ischemia. And you can see some of the measurements in this patient at baseline. He had no blood pressure in his toe, no waveform in the toe when we measured his blood pressure there. 3 months after having a single dose of CD34 cells, his blood pressure was elevated in the toe. He had a nice waveform at the toe pressure. Ralph did not care about these measurements. What he did care about was that he no longer had to take narcotic pain medicines, and he could go out and walk around on the golf course. So really a single dose of his own body's healing cells, and Ralph was a new man and back on the golf course. Our colleagues in Japan have performed a number of studies as well. You see an example from one patient here who had gangrene of the toe. 12 weeks after a single dose of CD34 cells, this patient's long-standing ulcer had healed completely, and the line graphs that you see simply document an improvement in blood pressure, oxygenation, and a reduction in ulcer size in the entire study population that was treated with their own CD34 cells. Similarly, another study performed by our Japanese colleagues showed that the majority of patients, over 80% of patients who entered the study taking narcotics for rest pain or having an ulcer in their toe or leg that was not healing after best medical care, 80 or 90% of those folks were cured after a single dose of CD34 cells, and that cure occurred over the course of just a few months. The other target area that I wanted to talk to you about is refractory angina. What's refractory angina? Again, it's due to reduced blood flow, in this case to the heart, that results in chest pain. This classic drawing by Frank Netter symbolizes the plight of patients who have this condition. They go outside and try to engage in an activity, particularly if they're challenged with cold weather, and they get chest pain that stops them in their tracks. They've failed medical therapy, they've failed stenting, they've failed bypass surgery. So really, they've exhausted the conventional armamentarium of therapies available to patients and are crippled with their chest pain. We've combined the data from 3 randomized double-blind placebo-controlled studies and showed that patients who received a single administration of their own CD34 cells had a reduction in chest pain, as shown in these bar graphs, improvement in exercise time. So they had less chest pain, were able to walk a greater distance, and most notably, there was a significant mortality benefit. So these patients survived to a greater degree, had fewer adverse events, had better exercise capacity, and less chest pain. And it's important to point out that these benefits occurred after 1 administration of their own CD34 cells, and you can see the time frame here. Patients were followed out for 2 years. So a single dose of a medicine that makes you better for at least 2 years and probably beyond that. Our colleagues in Slovenia did studies in heart failure, and here you see a 5-year graph of patients who received a single dose of their own CD34 cells, and this is looking at their heart muscle function within a year, but maintained out to 5 years after a single dose. The patient's heart muscle function had improved significantly. And again, most importantly, a single administration of those cells resulted in a 5-year survival benefit. There is something very different happening here. This is not like taking a blood pressure medicine to lower your blood pressure until you take the next pill. This is a single administration of a naturally occurring repair cell that actually repairs the organ and returns it back to a state of health. The key message, and I think you're hearing this over and over again on this panel, the science of cell-based ischemic tissue repair has now established the possibility of clinical tissue repair and regeneration. This will unburden patients of their disease, allowing them to lead more healthy and productive lives, and will unburden society as well. Restoring health will be shown to be more cost-effective than managing disease. We have some ongoing studies in the United States. We're performing a study in patients with coronary microvascular dysfunction. We used to call it Syndrome X back in the old days. Chest pain that results exclusively from microvascular disease without the epicardial coronary clogging that is typical in atherosclerosis. And our colleagues at Cedars-Sinai and the Mayo Clinic are doing that study, which is up and running. And in Japan, we're doing a study of critical limb ischemia treatment with our colleagues there. And there's actually 4 patients enrolled in that study so far. With that, I'll thank you for your attention and be happy to answer your questions. Thank you.
We're going to move on to neurodegenerative in a second, but let me ask one question now. You know, you think about someone who has critical limb ischemia and they got no blood pressure, they got pain in their foot, and they're at risk of losing tissue, developing gangrene. It seems like a sort of urgent or emergent issue. How quickly would cells like this work?
That's a great question. So, you know, rebuilding the blood vessels in the leg does take time. So if we look at the data from all the studies that we've done, generally you start to see improvement within 2 to 3 month windows. So there really is a biological cascade that needs to occur. So this is not an emergency type procedure like an angioplasty or a stent where you restore blood flow right away. You do need a period of time to get patients better. I see this, certainly it's a standalone therapy as a possibility, but also an adjunct. As you know, many patients who undergo bypass or angioplasty for CLI, those grafts fail after a period of time, and the surgeons will tell us it's because of bad outflow. No flow through a graft puts the graft at a high risk for failure. So we think there may be a way to use this in conjunction with, improving the blood flow through the superhighway, if you will, but the little tributaries that actually feed the muscle tissue need to be repaired as well, and maybe simultaneously.
Got it. So certainly for emergent or urgent patients, maybe as an adjunct therapy. Yes. Okay, thank you, sir. Dr. Ahlfors.
So I'm the CEO and Chief Scientific Officer of Fortuna Fix. We are a biotech company that specializes in the CNS neuroregeneration field. And I'll be talking about our technology and where we see the future of stem cells in terms of being able to actually cure CNS degenerative diseases. So our mission is to cure the CNS degenerative diseases and both traumas and various diseases with ethical next generation regenerative medicine products. Now, for any kind of therapy, there are two things that really matter. So one is safety, and the second one is efficacy. However, for cell therapies, there are two additional things on top of that matter. The first one is you want to match the cells as closely as possible to the patient. And the most perfectly matched cells, of course, would be autologous cells, so cells that are patient's own. But these are generally either cost prohibitive or not available in the right types of cells. So the second additional thing that matters is that you have the right cell. So just like drugs, there are different kinds of drugs, like a painkiller is very different from an antibiotic. It's the same with stem cells and cells. There are different kinds of stem cells for different kinds of diseases. Each organ has its own kind of stem cell. The heart has cardiac stem cells, the brain has neural stem cells, bone marrow fat, mesenchymal stem cells. And what we are working on is on what we consider the most difficult area, which is the brain and the spinal cord, in terms of getting these cells. And the reason I say that is that most patients, once you reach adulthood, you don't really have many neural stem cells left in your brain. And especially when we start getting older and we really need those cells, there really are almost none left. And very few patients, I think, would be willing to go and take a brain biopsy to remove the few remaining neural stem cells to then try to treat something else. So the difficulty has been how to get these cells. I mean, for bone regeneration, cartilage regeneration, it's quite easy because you can use either fat-derived or bone marrow-derived cells that are mesenchymal stem cells, as long as you just get the right cells and the right process. And same for blood. We've been curing leukemia already for decades using hematopoietic stem cells from blood. But the big barrier has been brain and spinal cord. So what we have developed is a way to really customize these cells for every patient and for every kind of disease. So for Parkinson's, what we need ultimately are not just neural stem cells, but we need those neural stem cells to become specifically A9 dopaminergic neurons. And if you don't do that properly, for example, if we get some serotonergic neurons in there in the mixture by mistake, you end up with something we call dyskinesias and other problems that have so far been plaguing this field in other Parkinson's studies done in the past. For spinal cord, you want spinal cord motor neurons and spinal cord oligodendrocytes, astrocytes, specifically for the spinal cord, not the brain, but the spinal cord. And you want them all to differentiate correctly and graft correctly. And this is really what we are working on. And of course, the first thing that comes to everybody's mind is when they hear about this sort of futuristic kind of stem cell therapy is the cost. And especially if we make it customized, how can we keep the cost at a level that this is going to be available for everybody, as opposed to just the few ultra-rich people. And for this reason, we have also developed a robotic manufacturing system that I'll be showing you, speaking more in a moment, that really has allowed us to reduce the cost. And this is the first fully roboticized manufacturing system in the world, where we had 14 different robotics manufacturers come together and really push the limits of the technology of what can actually be done with robotics and cells. So now going back to science again. Now, if you look into nature, how does nature really regenerate stuff? And I mean more like rebuilding things. So if you look at salamanders as an example, here you see a salamander you can cut the limb off and the limb will completely grow back. And the question is, how does it do that? I mean, it's one thing to grow be able to regrow everything, but how does it grow in exactly the same kind of limb that looks exactly the same as the original limb? How does it organize and self-organize itself in empty space, knowing exactly how to become what it needs to become? So I started studying these salamanders 15 years ago while I was still at university. And what I found was that there's something called direct reprogramming that goes on in these cells. So salamanders have a lot of stem cells, but the stem cells are more used for maintenance of tissues. They're not used so much for actually rebuilding lost tissue. For rebuilding lost tissue, it uses something called what we call precursor cells, directly reprogrammed precursor cells. And in this process, cells are essentially taken a little bit back in time, reprogrammed, and made into the different kinds of specific precursor cells to regrow the limb. So there's precursor cells for the muscles, there are precursor cells for the nerves, precursor cells for the bone and the skin. And they all know how to self-organize in their own different way. So the big question when we found this was, can we find a way to recreate this using human cells? And in the next slide, the answer is yes, we did. So we essentially mimic the process that goes on in nature when it comes to rebuilding new tissues. And it's a bit complex, but essentially the idea is that all the cells in your body have the same DNA, the same genome. So everybody always talks about genetics, but that's really not the full picture. Because, for example, your skin cell and your brain cell have exactly the same DNA. But clearly a skin cell looks very different from a brain cell. So you can't just say it's genetics. So it's not just a question of genetics, it's also a question of what we call gene expression. How much is each gene being activated by? So a skin cell has some genes that are more active and other genes that are not so active. And in nerve cells, it's a different set of genes that are active and not active. So if you want to reprogram a cell from one type to another, essentially the idea is that you need to find a way to turn off the genes of the cell type where you start from and turn on the genes on the cell type that you want to become, and become very good at specifically doing that in a very reproducible fashion. And in this scenario, you have to essentially open up the chromatin, do some DNA remodeling to be able to access those parts of the DNA that are now silenced, and turn on the genes that are active. The reason why this process was important is because, like I said earlier in the presentation, we didn't want to go into the brain to take these cells for regenerating the brain. We wanted to go to some part of the body that's easily accessible, doesn't really cause any permanent damage to get these good cells. And so we can now use cells from the skin, so we can take a skin sample, we could use blood, or any of the traditional bone marrows and fats as well. But we don't, but those cells are then reprogrammed to the type of cell that we want. In terms of manufacturing, it is a bit of a process. It is a 6-week process to make these cells. So essentially, the patient comes to the clinic. A cell sample is taken from the patient, sent to our manufacturing facility, where this robot that we have developed essentially takes that sample and processes it all the way through and reprograms it, expands it, freezes it down, both for the shipment and also for being able to do additional transplantations if needed in the future after that. So one robot can make 10,000 patients a year, and it's all done without any human intervention or any animal components or genetic engineering of viral components. So very sort of translatable in terms of commercialization. So here in the background on the picture on the left, you sort of see the surface of the robot. So one robot is about 10 square meters in surface area. Here are some of our advisory board members. On the left, you see Dr. Michael Failings, so big spinal cord neurosurgeon. And then we have John Dunlop, who is the head of the neuro department at Amgen. And on the right, we have Dallas Hack, who was the head of the TBI program in the US military. And you'll see some pictures of the cells, the neurons that we make using the patient cells. Now, what's interesting is that when we test these in animal models, what we have seen is that these cells can actually outperform fetal neural stem cells. And so far in the sort of hardcore scientific community, fetal neural stem cells are seen as the more or less still the gold standard in terms of being able to regenerate the brain and the spinal cord. So this is a stroke/TBI model. And you can see that the yellow line are these fetal neural stem cells that have a very significant effect over control animals in regenerating these animals and getting functional improvements. But what's interesting is that these directly reprogrammed cells have an even greater functional improvement over the fetal cells. So not only are we able to make these cells that are now customized in the patient's own and the right types of cells, but they actually outperform fetal and embryonic derived cells. This is a model in a primate. So again, animals that didn't receive the cells had no improvements in the spinal cord injury model. And all the animals that received the cells had very significant improvements. Score goes from 0 to 16. 16 is actually normal. So many of the animals return back to normal in terms of their spinal cord injuries. Also had an exploratory human clinical trial where we see the same exact trends that we see in the primate experiments, where each patient had a very significant increase in their performance and function, and both motor and sensory and also different autonomic functions. And we could see EMGs, MEPs, and SSCP signals improving in these patients. So to conclude, these cells allow us to make personalized cells that can now actually replace brain cells and spinal cord cells, as opposed to just creating a regenerative environment and releasing some exosomes or growth factors. We can actually create the cells that are missing and replace those cells. And so this means these cells are applicable for all the different neurodegenerative diseases, the different neurotraumas, the strokes, and even aging. We've also developed a process to rejuvenate the cells, because obviously one of the issues we found was if you take a 70-year-old patient that has a stroke or Alzheimer's or Parkinson's disease, we need those cells to perform just as good as in a patient that's a 20-year-old. So we have also developed some IP over rejuvenating cells to get those cells from older patients to perform just as efficiently as from younger patients. And the process is very, very quick compared to iPS technologies that take many months. It can take up to 6 months to make autologous cells during that method, and it's very cost prohibitive. So this process allows very rapid creation of these cells. And as we saw earlier, the performance also is greater than what we have seen with iPS-derived cells. Thank you.
We're almost out of time, and I know there's a lot of questions, and hopefully you'll stick around. The audience members have questions. But Dr. Glassberg, let me just ask you, it's interesting, philosophically, this idea of using stem cells, almost the idea of you have a treatment in search of a disease in some ways, versus how I think we typically think about things in medicine. Do you think about stem cells potentially being used preventively or earlier in life, childhood asthma or something like that, for example?
So that's a really great question. So if we had the biomarkers to be able to predict, right? If we had even the DNA ideas of where the injury might occur, we could predict who would get it. I love the idea that it could be preventative, right? So that's the whole idea of looking at the bronchiolitis obliterans model, is that here you have, a living transplant, a patient who's going to get a transplant. Could you, in that model, prevent what you know it is inevitable? The rejection, right? So that's probably the best model we've got because we can, in a sense, manipulate it, Sanjay. The asthmatics, we could try, obviously we're going to look at children. Once we get the safety here, we'll be able to move into, we hope, is a big trial in kids. Because it makes total sense now that we've looked at these inflammatory pathways that we go that way. But in terms of answering your question, I'm very excited about the lung transplant piece because I think we can try to look at it there. But that would give us an idea. It could also give us, of course, help in treatment in the sense that we could look at patients who've already had the transplant, see if then they don't go on to BOS. I'll give you a little anecdote, is that 2 of the patients that were in the initial ETHER trial, most of these patients had 3 to 3.5 years prolongation of stable lung function. 2, however, did decline and went on to lung transplant. It's very interesting, though. They're both over a year out, and they don't have any evidence of rejection on pulmonary function tests. They get surveillance biopsies, so we should be able to see it, and we're not seeing it. But once again, it's a dream, right? We need to do the study. But I love the question.
All right, well, thank you. How about another warm round of applause for our panelists? Thank you very much for being here. Thank you. Thank you.